So indications for arterial blood gases in a baby. The baby is having signs of respiratory distress. And it can be nasal flaring. Nasal flaring. Now, nasal flaring is where the baby will widen their nostril, try to widen their nostril in an attempt to get more flow into their lungs. Okay? The baby has retractions. Okay? Retractions are like when their skin begins to sink in, okay, instead of going outwards during inspiration. What causes that is airway resistance. The baby is trying to overcome airway resistance inside their lungs to breathe in. So the retractions can be on the sternum, the breastbone. Okay, we'll call that sternal retractions. Sternal retractions. Or it can be at the top of it, right here. We'll call it supra sternal retractions. Or it can be between their ribs. Okay? And we'll call it intercostal retractions. Usually when they have this, they start the baby on CPAP. Okay? They start the baby up on CPAP. So if the baby is now gotten to like FiO2 of 60, or maybe a little above, and they're not still improving, then they get intubation. Okay? But usually CPAP. Cyanosis is another thing. Okay? Now, cyanosis is a less sign of hypoxemia. Okay? It just means that hypoxemia has been going on for a long period of time. When somebody is cyanotic, they're going to turn blue. Okay? They have central cyanosis. They have blue. They turn blue all over. They have peripheral cyanosis. They have bluish extremities. Okay? So when you get somebody who is cyanotic, they have central cyanosis, you give them plenty of oxygen. You put them on non-rebreather device, not nasal cannula, because they have been hypoxic for a long period of time. Okay? So another reason why you would want to do a blood gas is change of clinical course, appearance, and vital signs. All of a sudden, the baby doesn't look good anymore. Okay? They're having problems. You want to do a blood gas and check out and see what is going on. You can obtain ABG 15 to 30 minutes after a change on the ventilator. Okay? Especially the tidal volume, the FiO2. Okay? Major change, you want to check your blood gases. Okay? Obtain ABG on a regular basis after patient is stabilized to correlate with non-invasive monitors. Like now, the entire baby, okay? The amount of blood in their body is about approximately 90 milliliter per kg of the ideal body weight. Now, a term baby will only weigh like 3 kg. So you multiply 90 by 3, you got 270 milliliter of blood, the entire baby. So they don't have enough blood volume. As a result of that, we don't like to do frequent blood gases from them. So babies mainly use non-invasive monitors, okay, like transcutaneous monitor, okay, capnography, okay, will tell us about the CO2. But when we have them on any of those monitors, initially we're going to do that one ABG, okay? And then we'll correlate, okay, the arterial values with the transcutaneous values or the non-invasive monitor values If they are very close, then we can use that non-invasive monitor for trending, meaning that at any given time I can look at the transcutaneous monitor and use the CO2 that is displaying to try to estimate the baby's arterial CO2. Okay, so they use a lot of non-invasive monitors. Sources of arterial blood in neonates. We can do umbilical arterial catheter. Umbilical arterial catheter. Now, remember now, the umbilical arterial catheter goes inside the ductus venosus, the umbilical cord. Once you cut that umbilical cord, and an hour or so before it begins to shrink, you can get a catheter in there, okay, inside the artery. Because once the baby makes that transition, then their artery in there is like ours. So if we get that catheter in there, we can use it as a line, okay, in the adult. So we can use it to monitor their blood pressure continuously if we need to do that. Or we can do frequent blood gas sampling if we need to do that, instead of sticking the baby, okay? So that's what it is. The baby doesn't feel any pain with that. That's another thing good about it. In the presence of PDA, in the presence of right to left shunt through the PDA, okay? Blood gas drawn from the right hand periductal organ will have higher PaO2 than that drawn from the USC. Okay, so what that means is that you remember the ductus arteriosus? Okay, ductus arteriosus, that's the second shunt. No, that's the third shunt that the baby's blood encounters. Okay? Now, preductal, okay, oxygenation is before the blood goes through the ductus arteriosus. Like it's flowing, okay, coming from the placenta, goes into the baby, and then goes into the right atrium, shunts over, and then goes into the pulmonary artery, and then it cannot go inside the lungs because of the pressure in there, and then it goes right into the aorta. Okay? So, if the ductus arteriosus is open, it's supposed to close after birth. Okay, it's supposed to close after birth. But if it remains open, one of the ways that we can make diagnosis of that is by checking our preductal or postductal blood gases. So you're going to draw a blood gas from a preductal organ. The right hand is preductal. Okay. That basically what it means before the blood flow passes the ductus arteriosus. And then we have postductal blood gas, okay, which will be blood gas from any part of the baby, okay, after the blood goes past the ductus arteriosus. So if you look at it, now the right hand is preductal, okay, the blood has not gone through the ductus arteriosus. But from here, from the waist down, is postductal. Okay, the blood has already gone through the ductus arteriosus. Okay, so the thing here is that the preductal PaO2 is always higher than postductal PaO2. Let me say that one more time. The preductal PaO2 is always higher than the preductal, the postductal PaO2. Okay, always. But now, if the preductal PaO2 is 15 points or more greater than the postductal PaO2, then the ductus arteriosus is open. You have patent ductus arteriosus. Let me say that one more time.
Yes, please.
The preductal PaO2, which is in this case your right hand, okay, you get blood from the right hand, is always higher than the postductal PaO2, like blood gas gotten from the UAC. Now, UAC is postductal, okay? Always. But now, if the preductal PaO2 is 15 points or more greater than the postductal PaO2, then the ductal saturosis is open. You got patent ductal saturosis. Another way that we can do that, instead of drawing a blood gas, is we can check their SAP monitor, check their O2 saturation on their right hand, okay? And then check their O2 saturation with the pulse ox on their leg, okay? It will be different. If 15 points more, then they have a patent ductal saturosis. Any questions about this? That's all it means, okay? Now, if a baby is receiving oxygen therapy, okay, you would monitor their oxygen therapy with the preductal PaO2. In other words, if you want to make a decision as to whether to increase or decrease their FiO2, you look at your preductal PaO2, not the postductal PaO2, okay? Because if you're looking at your postductal PaO2 to make adjustments in the FiO2, the preductal PaO2 will go through the roof. Okay, so remember that. Complications of umbilical arterial catheter. Thromboembolism, where a clot can form distal to the tip of the catheter. Okay? Now, if that clot breaks loose and follows the blood flow, it may end up inside the baby's lungs. That will be pulmonary embolism. It can go to their brain. That can stroke them out. It can go and block their heart. That will be a heart attack there. Okay? So that can happen. Hypertension. It can cause hypertension because of the diameter of the catheter. There's obstruction there. Pressure backs up to the left side of the heart. Infection. Okay. If we want to put in the umbilical arterial catheter, we have to have like a sterile field. You know, we want to make sure that we wash our hands and nothing that is dirty is going to come into the sterile field, okay, to prevent infection. Hemorrhage, the baby can bleed, okay, especially if they have hemophilia. You can have vasospasm, okay, and then you can have necrotizing enterocolitis. You have inadequate oxygenated blood flowing to the intestine. That can result in infection. Okay? There. Any questions? And then another way that we can do that is that we can get a blood gas from what they call the radial arterial catheter. So this is pretty much like a line. Okay? They put it in the radial artery of the baby. And then you can draw blood gas there if you need to, if you don't have any UAC. Okay, or you have already pulled it out. Okay? So it says that RAC provides good knowledge of the preductal PaO2. Okay? Hazards include infection, arterial occlusion, or nerve damage. We can stick the baby, but we don't really like to do that.
How much can you take? How much would you?
For the baby? Very small. I would say like maybe less than 1 milliliter. Just a little bit. Okay? There's something they call the microsample. Like if you're going to run your blood gas, okay, if you press microsample on the blood gas analyzer, That means that the machine can use a small amount of blood. But you're not gonna draw 2 milliliter from a baby. That would be too much,
I
okay?
think there was a question on that practice exam, I can't remember
Right.
exactly how it was said, but it was something.
So, I mean, the most, if you're doing 1 milliliter, no more than that, okay? No more than that. Because now, if you're gonna do blood gas frequently for some reason, and you're doing 1 milliliter each time that you draw, you're going to deplete the blood volume, okay? They usually do microsample. Okay? All right, so ABG sampling is difficult through this route in neonate compared to adults. Arterial puncture inflicts pain to the neonate and results may be inaccurate due to neonate crying and fussing. Yeah, they start crying, they get anxious. You get a blood gas that is respiratory alkalosis. Okay? So that will mess up your blood gas. If you have to do arterial puncture, then you're going to have to do your Allen's test, okay, to determine collateral circulation. Okay? You pinch the ulnar artery and the radial artery, kind of close and open your hand, and then you let the ulnar artery go while you're holding the radial artery. Just make sure it picks up. Okay, if it does, then you have collateral circulation. Now there is capillary sample. Capillary sample. Okay, if you don't want to do arterial sample, you can do capillary sample. Now the only problem with capillary sample is that it is not arterial blood gas. It's a mixture of venous blood and arterial blood. Okay? So because it is mixed up, it will not give you accurate PaO2. And by the way, the tissues have already used up the oxygen anyway. Okay? So the PaO2 from arterial sample will be always higher than the PaO2 from a capillary sample. Okay. But now the pH and the CO2 will kind of like correlate. So most of the time when you do capillary sample, we're more interested at looking at the CO2 and the pH. Okay? The only correlation that you're going to get between the arterial PaO2 and capillary PaO2 is that, okay, anytime the arterial PaO2 goes up or goes down, the capillary PaO2 goes up or goes down. You know, that's the only thing you're going to get. You know, so sometimes they can use it. You know, like now, if I'm looking at the capillary PaO2, if I did it and then found out that it went down from the previous time, that can say, well, you know, the arterial PaO2 went down as well. But, you know, they're not the same. They're not very close at all. Okay? So now let's see what this here says. Capillary sample is mixed venous and arterial blood, not arterial sample, used when UAC is not available and ongoing blood gas monitoring is required. Useful in assessing pH and CO2, it is not reliable in assessing PaO2. Okay? There is no set normal for capillary PaO2. Okay? Other than it is slightly lower than the arterial PaO2. Okay? And then it varies from patient to patient. Okay? You get them out anywhere between 35 to 65 will be about normal arterial CO2. No, capillary CO2, sorry. Okay, but there's no definite number. Okay. Indications for capillary sample. arterial access is unavailable. You're not able to get blood gas from an artery for some reason. Non-invasive monitors reading are abnormal. Change in patient's status. All of a sudden, they don't feel well anymore. Contraindications. Posterior curvature of the heel cannot be punctured. The way you puncture them is like you can puncture here, about right here, okay? Kind of on the side. That's where you puncture them. What do they call it? Prick, right? Yeah. All right. No puncture to the heel of a patient that can walk. Okay. By the way, babies cannot walk. If you see them walking, they're right. It's not real. No finger puncture or puncture on previous sites. Okay, so make sure you're not puncturing at the same place that you punctured before. Okay. Complications, infection can result, burns, hematoma. You still have to press it down, make sure it stops bleeding. That's what causes that. Nerve damage, bruising and scarring can result. Okay, so again, here is normal PaO2 for a baby. Like I said, now 50 to 70, no more than 80. Okay. Studies have shown that anytime a baby's PaO2 goes over 80, they're likely to have that retinopathy or prematurity. That's where the oxygen damages their eyes. They can get blind from that. Their CO2 is like ours, really. Okay. But their pH can be like ours or slightly low. I think I've said this before. If you're a baby, if you get a pH that is 7.30 and above, you don't really have to worry about it because their alveoli are still developing. Okay, the alveoli increase in number throughout the pediatric years. So the gas exchange is not 100% like ours. So that's why you will accept a pH that is 7.30 and above. Okay? And then bicarb is 22 to 26. What is different, let me say this, I think I have it on this side. What is different is base excess. And here is base excess for an adult. Okay, so now we're back at 22 to 26. Normal in the middle is 24. But everybody cannot be 24, okay? So if you are 26, you have plus 2. That means that you gained the base. You gained the bicarb, that's all it means. Base excess. If you are 22, you have negative 2. You lost 2 units of bicarb. Okay. So that's what's considered normal for an adult. Okay, it can be 2 below or 2 above. Okay? But now, if my bicarb is 28, I will have plus 4. Okay. Okay, so it's nothing but how much bicarb did you gain or how much bicarb did you lose. Okay? So sometimes you can use them to determine whether someone is acidotic. For instance, if you have metabolic acidosis, you're going to have base deficit because you're losing base. Okay? If you're compensating for if you're compensating for respiratory acidosis, you're going to have base excess. Okay? So it's nothing but how much did you gain and how much did you lose. Now, for the baby, normal base excess or base deficit is plus or minus 4. plus or minus 4. So in other words, if the baby has a base body count that is 20, that will be fine. Okay, that will be fine. You have 28, that will be fine for a baby. Okay? So one more thing I need to tell you is that anytime a baby has metabolic acidosis, look at their PaO2. Okay? Usually they will get metabolic acidosis as a result of lactic acidosis, which is caused by inadequate oxygenation. Okay? So if their PaO2 is low, you give them oxygen, not bicarb. Okay? Causes of respiratory acidosis in a baby. BPD. Now we're going to start going over this here on Friday. Now BPD is like a chronic lung disease of the baby. Chronic lung disease of the baby. Just like adults have COPD, the babies will have BPD. Broncho. Yeah. See how to spell that. I gotta look that up. This page here. Bronchoporo dysplasia. I don't know where the E is there, but I looked that up. Okay, but now bronchoporo dysplasia, like I said, is chronic lung disease of the baby. When babies have it, their blood vessels will look just like an adult that has COPD. Okay? And what causes that is when we try to treat a baby who has RDS, respiratory distress syndrome, okay? We treat them with high pressures and high FiO2s on the ventilator. After that, they will get this. So the treatment for RDS, respiratory distress syndrome, in a baby is the cause of bronchopleural dysplasia. Okay? So that will cause respiratory acidosis. Respiratory acidosis, because their lungs are going to be very, very stiff. Okay? Meconium aspiration. That can get down into the alveolus. When the baby aspirates meconium, it goes all the way down into the alveolus and decreases the baby's lung compliance. Okay? And if lung compliance is decreased, it means then that the baby will not get adequate tidal volume in. Okay? And therefore, they will have respiratory acidosis. Their CO2 will begin to rise. Transient tachypnea of the newborn. This is where most of their lung fluid is not removed, okay, afterwards. Okay, so it's going to be like you have a lot of, it sounds like pulmonary edema. You have a lot of water inside the alveolus. Pulmonary edema, that's what I would call it. And that will prevent the baby's lungs from expanding. Okay, and that will cause respiratory acidosis. Maternal anesthesia before delivery. Yeah, a mother is given pain medication, okay, morphine or Dilaudid. That will cross the placenta. It crosses the placenta and affects the baby. Okay? When the baby comes out, the baby has poor muscle tone. Okay? They can't breathe effectively, which will then cause the CO2 to begin to rise. Sepsis, infection. Sepsis is like infection that has gone all over the body. Okay, infection that has gone all over the body. Metabolic disturbances. Now, metabolic acidosis, that's one thing with metabolic acidosis. When you have metabolic acidosis, normally we're going to give you sodium bicarbonate, okay? But there are patients that don't respond to that right away, okay? The way that the body compensates for metabolic acidosis is for the patient to breathe very fast, okay? So if they're not responding to the bicarbonate that you're giving to them, they're still breathing 46 times a minute. But now, how long do you think they're gonna go doing that? So they go, and then all of a sudden they're tired now, they go. Okay, so when they slow down going fast because their respiratory muscles are weak now, okay, their tidal volume will drop and the CO2 will go up. Okay, so the first intervention for metabolic acidosis is bicarb. But if they're not responding, and now their CO2 is beginning to rise because they're getting weak, then you intubate them, okay? All right. Trauma to thorax. Okay, the thorax is not able to expand. Now remember now, for you to breathe in, you have to drop your diaphragm and then enlarge your rib cage. Okay? So if you have trauma to thorax, that may cause the baby to lose mechanical advantage during ventilation. And they're not going to suck in a lot of air. Your amount of tidal volume that you breathe in depends on the amount of negative pressure that you create to breathe. The more negative pressure that you create, the more your diaphragm descends, okay, and your rib cage goes outwards, the more negative pressure that you're going to create, and the more flow that will come inside your lungs, okay? We have to take a break here. Let's take a break. And then we'll finish up. Let's take a break till like